am in amazement. It is week 9 already. So this week it's your reviews. I do the first review on Tuesday night, 5:30. Again, they'll all be posted. They'll all be recording as soon as I get them. And I keep them in one announcement. So you're not looking for 3 different announcements because there's 3 different pediatric professors. So you'll have them all in one place. I do it on Tuesday earlier in case if you're looking and reviewing the exam study guide and you have information that you're just not getting, don't understand, I'm available Thursday afternoon and Friday afternoon to help you. So send me a message and I'll visit with you. Let's, meet online, we can Zoom, go over those things, and I can try to help you. I think that I just finished doing again the PowerPoint for the review. Took my time, looked at it, looked at the exam, looked at the HESI, information that was absolutely vital, and I made sure it was there in an understandable way. So if you need help understanding, please reach out. I don't mind meeting with you one-on-one, or if 3 of you want to come at one time, because I know some of you all study together, that's fine too. Let me know what time is available for you all, and I'll work with you to get that done, okay? Because, those scores reflect on how I teach too. So why wouldn't I want to help you? And my goal is for everybody to do as best they can, all right? I try to teach very understandably, very simplistically, so that it makes sense. And I think nursing is common sense in many different ways, and just having little information and then working with it. Let's make that, what do I do with that information? What does that mean? And, how can I answer that question? So this week you have a discussion question due. You have Kaplan. Now, what it says on your syllabus is, I believe, let me see, I have it right here, syllabus right in front of me. It says focused review math, pediatric math A. Well, there's an advanced in the word too. So it's advanced pediatric math A. It's the only one that looks like that. The wording is different. The funny part about that is I changed the syllabus to reflect the new name last semester, and they changed the name again on me. So it's a new name, so I'll be changing it for next semester. Maybe they'll change it again. Drive me crazy, but it's all right. So that's what it is. Make sure you do your remediation on those. Now, I have to go in and look at every one of you on the Kaplan site. I don't accept screenshots. So I usually do math and the A, B, and C Kaplan all at the same time, because it's every student, and then every campus has their own site. So there's 16 campuses. There I have 85, 90 students. So it's one at a time. So you have time to get it in. And that's what I'm trying to tell you. You have time to get it to me, because I don't look at it till after A, B, and C are in there too. Because I can't go in there 3 different times. That's 200 and some odd views of it. And that's just a little bit too much. You have your discussion question due this week, discussion 6, and the pediatric practice exam. If you can't get into something, just let me know, so that I can make sure it's an error where, send out a help ticket, whatever. I've had some problems with other exams. So let me know if you can't, and I'll help you. If y'all haven't turned in your pediatric assessment project, make sure it gets in this week. It is minus 10% for this week, but it is 6% of your grade. And you can actually fail pediatrics because of not having this assignment in. So please don't do that. Now, I will send you some information back. Why isn't a perfect grade? You can take it, fix it, send it back to me, send me a message that you've done that, and I'll increase your grade only up till this Sunday. I've been doing that since people started turning the grades in. I want you to get the best grade you possibly can, because I know going into the HESI, everybody wants to have the best grade that they can, because most students do struggle with a HESI, okay? So I will be doing that back and forth. I will be doing these projects, reviewing them on Tuesday and Wednesday. They should be done. So just go back and check. If you're not a perfect 100, find out why. If the grade isn't good enough for you, make your revisions and send it back to me, okay?
Excuse me, Professor Bogart.
Yes.
Did you get my my resubmit yesterday? I didn't send you a message. I didn't know I was supposed to send you a message.
Well, let me take a peek. Yes, I do. And it's perfect. Thank you. The numbers are good
Thank you.
now. The numbers are good. I did send back yesterday, late afternoon, early evening. I went through everything that was submitted and sent back to some students. Most of it was plagiarism. And it's just change up the words a little bit. You know, plagiarism is a really bad word, but I understand, you know, some of these things, it's hard to change words because it's what it is. You know, just switch the sentence around. That's all you have to do to make sure it's in. Okay. So we'll do our PowerPoint and then we have a Kahoots. I think the Kahoots is only like 40 questions today. So we'll get through it pretty quick. So any questions on anything? You're all good. All right. Stop me if you need anything. And I will start with our PowerPoint. Now, this is all about musculoskeletal, articular dysfunction, and neuromuscular type of problems that go on with children. And you'll see as we go along. The immobilized child, it doesn't matter if you are a child or adult. If you're immobilized, there are going to be some issues with the body, but there's also reasons for it. Many children, you know, they're not born perfect and they have some disorders. It could be congenital, it could be just degenerative, like it gets worse as time goes on, or it could be something that requires a child to be immobile for a period of time in order to heal the condition that's going on. So remember, when we have an immobilized child, to worry about things like muscle atrophy and skeletal bone demineralizations. And I think the most complex of all and the most concerning is cardiovascular, your heart, your lungs. Make sure that the body, you know, is pumping good blood around, that we're not going to have venous stasis and edema, blood clots, and then congestion in the lungs, you know, doing all those things we need to do to prevent those conditions. Having a child immobilized is very difficult. If you have a child who's immobilized, who's in bed, who can't move, they get very frustrated after a time. So we need to have them in an environment that, you know, they're able to do some things, you know, give them their iPads, let them play some games, watch some TV, you know, read a book, things that help them, and, you know, have people visit them. It really helps. You know, children that are stuck in bed for a period of time, could be just a week, you know, they're going to get frustrated. They're either going to get aggressive or they're going to regress, either or. If you are that family of a child who's going to be immobilized for a long time, it's frustrating on the family and the child. What if you have a child who, you know, requires, you know, total care, where they have to be lifted from bed to wheelchair, you know, has to take care of their functions, their urine and their stool, and changing and turning and positioning and dressing and feeding. You know, this is a strain on the family. And the one thing that I really enjoyed about the hospital where I worked, Nicholas Children's Hospital, is each floor was specialized with certain diagnoses. And they did have the cardiac family, you know, monthly meetings where family can get together and talk about their frustrations, and they can help each other. When somebody else is going through the same things as you are, it really helps. And those parent groups, and even having children in counseling to be able to verbalize themselves, so important. So injuries, getting into injuries, traumatic injuries. you have muscles and ligaments and tendons, and you have bones. And, children play and they fall and they hurt themselves. It could be, walking out the front door, chewing gum, tripping over their feet, and falling and bruising, etc. Or it could be when they're in sports. I think the most common is a contusion, which is basically blood underneath the skin. Now, don't be so passé about contusions. They can get swelling underneath. They can occlude blood vessels. So even if it doesn't look huge on the outside, remember, it could be occluding a blood vessel. So nursing care, make sure you're checking neurovascular signs, checking for pulses, because sometimes it can be diminished. And when you're not getting blood where it needs to do, you can have necrosis of tissue. Dislocation is something that can happen. Not a lot in children, but the most common is nursemaid elbow, where the elbow, because of the nice, soft, loose tendons, tends to pop out of joint. And then the arm will be hanging to the side. This is caused by usually your young children, 2 to 4, where you take their arms and you swing them around because they love it. Because, wee, that's fun. Again, daddy, again. Well, sometimes the elbow can pop out and it's called a nursemaid elbow. It requires a physician to take it and just pop it into place. And then it's back in. And we'll put them on a little splint and then it will, heal and it will be okay. And then we're not going to swing around by their arms anymore. Now, Down's children are special. They're extremely flexible. They can take both their feet and put them behind their head at the same time. The problem with having a child doing that is their tendons are so soft and flexible, you could pop their hips out of joint. And when you pop them out of joint, you have the problem that you might occlude the blood supply going to the hip joint, and it could die the head of the femur, which then would mean a hip replacement, which we don't want to do. Sprains, I think, are the most horrible thing that happen. I probably have had 20, 30 sprains. I was a sports kid, especially playing volleyball. You go up, come down, and you right on the ankle, and oh my God, you can feel the as it rips the tendon. And then, of course, you feel the swelling occur immediately, and it's extremely painful. It's harder to heal than a fracture because it's just a lot of swelling and inflammation in there. Strains are when you do something to an area, maybe it's an overuse thing, but you've ripped some little tendon in there and it causes pain. It's not a immediate like a sprain, you land on your ankle, but it's over time. So how do we take care of these? Well, it's the rice. You rest it, immediately stop, put your leg up, get ice on it. But remember, ice causes vasoconstriction. So you can't have ice on more than 30 minutes. So then you allow the blood back to flow there because normal tissue just needs, the oxygen and the nutrients from the blood, and then put it back on. Put on the ACE bandage, it just makes that swelling. It's not going to swell as much, and you elevate it so you can decrease the swelling that's going on. They do a lot of immobilization. Even a lot of times now with bad sprains, they're going to put a cast on it, to keep it in position. And actually it helps with pain, or they can just put a little splint on it, with an ACE bandage to keep it in the proper position. So fractures. We know fractures, kids are breaking bones. I think the most common is when they fall, they put their arms out. Whether it's one arm or two, they fall, the arm goes out, and then you fracture your radius and your ulnar, one or both at the same time. A couple years back, they came out over Christmas with this hoverboard where it's just, you get yourself going just by putting your feet back, and then you would go. And the kids thought it was great. They put on their helmets, but they didn't have wrist guards on. That Christmas, I saw 3 children come in with bilateral, both bones broken in both arms. Very dangerous. They didn't have wrist restraints on. Very dangerous, because you fall, what do? You put your hands out. So 2 casts were put on these children. I mean, most of the time we see fractures, it's either from sports, bikes, and just, falling and putting their arms out. Now, if you're an infant and you have a fracture, um, fractures in an infant are very difficult to do. Their bones are very soft and they're flexible, and it would take a heck of an impact in order to fracture a bone. So if we have an infant with a fractured wrist, a fractured femur, something's wrong. There's something not right there most of the time. I'm going to tell you a story. It's not a nice one. It was a 3-month-old little boy came in with mom holding the child, very tearful, saying that there was some swelling behind the ear and a little bit of discoloration. And she was crying, and the place was busy, but I said, no, bring mom in. She's upset. Let me take care of her. So the first thing I do is put my arm underneath, my hand underneath the head to support it, underneath the buttocks, to put it on the scale to get an accurate weight before vital signs. When I put my hand underneath the head, my fingers went into the skull. It was mush. And the kid cried. So now the red flags are going off. And there was like old bruising, like that yellowish sort of color behind the ear. So I made an alert to it, went talked to the physician, the charge physician, let him know my suspicions. And he said, go get an x-ray. And if you see something, do what we call a bodygram, which means put the infant on an x-ray plate and shoot the whole body. Let's see if there's anything else. Well, the kid had a fractured skull, but he had an old fractured humerus. He had old healing fractured ribs, had a fractured femur. So what did we do? Our job. Now, did I want to beat the mother up? Sure, she had the child, but I didn't know if it was her. My job was to take care of that child and keep it safe. So there was a twin. We brought that kid in. We did x-rays, same injuries. Brought a 2-year-old son in, same injuries. The kid was walking around on a fractured femur. So what happened? Well, because all of these 3 children were involved, they all had very suspicious injuries. We knew it was abuse of some sort. We admitted all 3 into the hospital together until we could decide who was doing this, because our goal as a nurse, and it's hard to hold your tongue when you see stuff like this, is to protect the child. So in the end, it was actually the father. The father did go to jail, and the children went home with mother. The story is daddy lost his job right after the twins were born. So daddy stayed home and took care of the kids, and mom was working 3-4 jobs to try to keep the family going. And apparently while he was bathing the children, they were crying, and he was, be quiet, stop crying. So he took the kid and slammed it against the tile surround in the bathroom. And that's apparently how this kid got this fractured skull. So the end of the story, because I knew the lieutenant of the child abuse squad of Metro Dade, he did go to jail, and the mother was cleared and the kids went home. But, abuse is horrible. So always be careful with infants. And, it's the hardest thing to hold your temper and your mouth, but your goal, keep the kids safe. So there's all sorts of fractures. It's basically open with a bone coming out, or all different other fractures, which is a crack or a bunch of pieces and fragments all over. The open or compound fracture is one that requires a little more nursing care. This kid has his bone open to the environment. So now we are concerned about infection into that bone. So in children, our biggest concern with bone fractures is if they hit the epiphyseal plate, which is the growth plate. Now, usually what I've seen with growth plate fractures are in the elbow. And that elbow, what they have to do, 1 second. Christian, I'm teaching. What, dear? Okay, he's right out front, but I'm here. Here, say hello and then go. This is my little guy. This is Christian. Just wave hello.
Hi, Christian. You are so cute.
Hello. Okay, now you can go sit outside and I can teach, okay? Yeah, look, they're waving.
No, look.
Yeah.
This one looks the same.
Yeah, that's you, Albert. Looks like our house. Okay, go ahead. Close the door. He likes to come in and say hello. Fine, pop. Okay, growth plate fractures, epiphyseal plate. These are something you just don't cast. Because if you don't have a straight bone, the bone is not going to grow properly. So you could have one arm longer, one shorter, or it could be crooked. So open reduction, internal fixation with plates and screws will hopefully make sure that that bone grows properly. Now, infants, they really heal quickly. Look at this, 2 to 3 weeks. So these children who need casting only need it for a short time. Adolescents, now we're getting up to 2 to 3 weeks, 2 to 3 months, right? And then us probably maybe even 3 to 4 months. We just heal slower. So children, they're so resilient and they heal so quick. So you get a kid coming in, fell down off of the monkey bars at the playground, complaining of pain in the wrist. First thing is you're going to do the history with the parents. Make sure, if you can, get that child alone and ask them in a non-threatening way, so what happened? Sometimes children, you have to protect, they're innocent. So, and they don't know how to lie good, especially the young ones. So what were you doing? You're on the monkey bars, were you all the way up there? Or were you trying to get up? Or did your brother push you? And they will answer very honestly, just because our goal is to keep these kids safe, okay? Now, sometimes we don't know if a kid has a fracture of the leg, but sometimes you can see that limping and just that little limp, or they don't want to walk on it. You're like, yeah, that kid's got a fracture. So our goal is to get it reduced, bone straight. So we're not going to grow, straight, not a crooked arm or leg or finger or anything. And we want it to be able to function normally, and we don't want a deformity. And those are our goal. So assessment of a fracture, you put a cast on a child. Now you see this arm that's all black. It can happen. I mean, it's the most, severe type of thing. But if we are not monitoring the fingers and the moving and the color and, the sensation or the swelling in there, these things can happen. So we don't want compartmental syndrome type, and that's because the cast is squeezing that arm. So we're going to be checking pulses. We're going to check capillary refill and the color and the movement and sensation. Very important that we do look at that and teach parents how to look at it too. In pediatrics, casting is actually a lot of fun. We put a lot of different colors on these children, and it actually sort of helps them not be as afraid, because they're going to get their special team's color or their special color, and maybe we put 2 colors on. If you look at this girl, even her doll has a little cast on, and that really makes this a non-threatening, because putting a cast on can hurt. So this is something to, that distraction. Teaching how to take care of these casts at home is very important. Of course, teaching them all about the 6 Ps. Also, to teach them not to get it wet. If it gets wet, they need to replace it then, not tomorrow, but today, because it's wet and then it's going to get moldy underneath and it can create other infections. It's not uncommon, and I've seen it more times than I can tell you. They come to the hospital, they have a fractured arm, they go home, they forget, They get their bathing suit on and go jump in the pool. And now you have a wet cast. I seen one kid did it 3 times. The mother was about to bop him over the head. She's like, I can't come to the emergency room again. You can't get this cast wet again. And it was sort of funny, but it's not, because it does take a lot of time out of the day to come and get a cast changed. Now, sometimes you can't put a cast on and you need to put traction. There's skin traction and there's skeletal traction. Now, one of the fractures that really benefits from skin traction is a fractured femur. So you have your long bone and it cracks, and each those little sharp pointy edges go into the muscles and the nerves and cause muscle spasms and a lot of pain. So you put traction on and it pulls the bone back straight. So now we've decreased muscle spasms and all of this into the nerves with these sharp edges. And it gives the surgeon a chance to be able to get the kid to surgery. And now what they're doing is putting a rod right down the middle of the femur so it's nice and stable. Years ago, they just put a pin, a Steinman pin in the leg, and the kid would be in traction for 30 days or more. So today they're doing things different. You know, as you become a nurse and see things, everything changes. There's nothing permanent but change that occurs with different sort of new methods of things. Now, what would be your goal with traction? You have a child placed in traction for a day or two before he's going to have this surgery. You're going to have it to a pulley and a weight hanging. That weight should never, ever be taken off. It should be free hanging at the end of the bed. And if it comes off, what happens is these bones now, which were nice and straight, get crooked again. The muscle goes into spasm, causing a lot of pain. So our job to teach the family and the child, leave it free hanging. Do not put it on a chair. It can never come off until they do the surgery. And as a nurse, you will document how many pounds of weight are on that child on every shift. So I've mentioned some of the things about traction, but it's really all about the muscles and keeping that bone in alignment so that you are preventing deformities, and that muscle spasms is a big things about it. Now, there's different sort of skeletal tractions. Here's a halo on this girl here. We use those for neck problems, neck fractures. I had a 16-year-old boy who came into the ER who had and it was a trauma alert. He slid into third base and his head hit the third baseman's knee. And you heard a crack is what they told me, you know, in the stands. And he had an like your C-spine should be like this. He had an angulated, like almost this angled C5, C6. He had some paralysis occurring in his lower extremities. So it was keeping that neck straight for what we needed to do. And we put him in a halo and we put him under sedation. And this kid today is normal and no paralysis. Now, there's all different sorts of tractions that we use, you know, and if we are, you know, using traction, you haven't used it before, you know, ask someone. Orthopedic techs in pediatrics, I have found really will come and teach you, and I'm glad that they do have them. You know, we have Bryant's traction and Russell traction. This bottom one is the Bucks one again. Then we have the halo. This is for the neck to keep that cervical spine straight too when they need to do surgery, or they need to do surgery and have that in. Sometimes we need to put an external fixation device on. Sometimes it's used when you have a leg shorter than the other and you want to get that short leg the same size as the other. And what they do is they break the bone, they put it in this device and pins go through. Okay, and it lets that bone form in between so we can make that bigger. Sometimes it's used when there's so many fractures in that leg that they need to support it this way. And it will help again to get the legs from not being shorter than each other, or deformed. Sometimes we have children born without a leg. I had a friend whose daughter was born without a fibula. You cannot put a new fibula in. They had to do a below the knee amputation. Now, I met this girl when she was 4 years old, and this little girl came to my home, took her leg off, and was crawling and up downstairs, beating my kids over the head with their prosthesis, and she was the happiest thing. And my kids were like, Mom, but she's chasing us around with her leg. And it was humorous, but it was also, she had really, really, adapted to her, if you want to call it some sort of, make her not as good as other kids, but she was just as good. Now, if this is an amputation due to trauma, this is the one that you're going to get those phantom pains and whatnot. And of course, we always treat phantom pain, and there's all sorts of new things that we can do in treatments. So we know sports causes injuries. It does. We know that kids are competitive in every little thing that they do. Making sure they have the proper equipment on and they're warmed up and they've got medical clearance to get there, and not to try to overdo really can help decrease injuries, but they're going to have injuries. Overuse syndromes is when kids keep doing things over and over again to be better and better. I mean, we can see this with the Olympics every year. These kids, especially those young gymnastic girls, they're 15 years old and they're keep doing the same things over and over again. And it could cause these little overuse syndromes, which you need to rest that area if you possibly can. Sometimes these overuse, we use traction again. Traction does relieve those muscle spasms. Now you wonder why pediatricians on the first visit of a newborn takes the knees and go up and down and back and forth. And what they're checking for is to make sure that the hip has the femoral head locked inside of it. And that's the way it should be. But many infants are born and it's up a little bit, okay? So it's out of socket. And our goal is to get it back. Now, we've seen that 2 to 3 weeks, we can heal things on infants. They heal very quickly. So immediately they'll take and they'll put these children in a brace, okay, to bring it back down. Now, pediatricians, when they're doing this click, they're looking for certain symptoms. And what they see is this. So this hip is the ball of the femur is way up here. So that leg will be shorter. Also, if you turn them over, the gluteal folds or the leg folds, one will be higher than the other. And those are things. And also there's positive Ortolani and positive Barlow tests. You're going to be hearing those clicks going on with these children. So we see those things. What are we going to do? From birth to 6 months, and it's, if we can find it at birth, it's the best. But sometimes it's barely out of place. This Pavlik harness, this little baby has here, again, 23 hours a day it should be on. You take it off to bathe them, put on something underneath, and you put the harness over, and it keeps those hips up where it should be. Most of the time, that will take care and put that hip socket back where it should be. If the kid are older, we will probably put them in a spica cast, which is, the casting with the bar in between, so we keep it in position. If the kid is older and it's still not managed, they're going to have to, these tendons now are locked and they're tight and you can't move them. They'll be doing this tenotomy, which means cutting the tendon and loosening it, trying to get that hip back into position. Another deformity could be clubfoot. Now, you don't need to know all the types of clubfoot. All you need to know about club feet is that the feet and the ankles, they're in, they're out, there's something, they're not the way they should be. And remember, they're very soft and malleable at an early age. So immediately, as quick as we can after birth, we will start doing serial casting. It's the best way. It is the Ponseti method. What they do is every week, they change the cast. So these parents need to come in every week to have cast changing. As they fix it and get that club foot better, then for life, you know, as they are growing, they need close follow-up of those feet to make sure that they are, you know, they're going to start walking, making sure they have good shoes. All of these things are going to be so important with a child with club feet. A little funny story is I had a little girl like this size with club feet, and the mother came in with the baby in one arm and a cast in the other. She had the cast put on the day before. Somehow the baby got out of the cast. She woke up the next morning and the cast was off. I have no clue how that child did that. Another condition is something called osteogenesis imperfecta. And this is brittle bones. These children, you can pick them up, put your fingers in their ribs, you can crack them. I mean, it's very brittle. It's a very, there's nothing you can do to change this child. You can give, you know, some sort of medicines that helps it a little, but these children will have multiple fractures their entire life. Our goal is to try to keep them that they can still at least get into a wheelchair and be mobile and be able to move. They do biphosphonate therapy, and they'll do calcium, vitamin D's, you know, vitamin things, but really there's no cure to this. I actually had this little boy who used to follow me to the cafeteria on his electric wheelchair, and he used to zip past me with an electric wheelchair. This kid was mobile and he had osteogenesis imperfecta. And I thought it was neat that he would go beep, beep as he going down the hall. And, you know, having a kid being a kid is what it's all about, even with something like this. Late calf Perth disease is a septic necrosis of the femoral head. It just happens. Why? It could be one side, it could be both sides, but this aseptic necrosis is due to lack of circulation for whatever reason. So sometimes what you'll see is the kid starts to limp, have some soreness, and then can't really move the leg as well as it should. And we'll see it mostly in the morning. When we do an x-ray to look, we might see some fuzziness, which is showing this necrosis there. So we need to do something to help them. And all we do is to put them on bed rest, no weight bearing, and NSAIDs for pain. Sometimes they put them on that traction, that Bucks traction, which pulls it, or some Bryant or Russell traction, which helps alleviate the pain. But usually, you know, in time and rest, it will reverse and it will be okay. Now we're going to look at some spinal curvatures. The first one is what we call kyphosis, which is a humpback. And it could be due to many different things, but it's a postural type thing. Lordosis is the lumbar spine, and it curves in, so you're almost arched backwards. And this child, it's usually due to some sort of trauma, and sometimes it's really due to nothing. It just, this curvature. Scoliosis is the most common of all those, and we call it an S-shaped curvature of the spine. They could be born with it, or they could develop it through their childhood. Now, when we usually see this and start the treatment is at that pre-adolescent growth spurt. Now they go 25% of their growth at this time, and all of a sudden you'll see this curve start going on. Now, how do we treat scoliosis? Well, this curve, they measure a degree of angle on it. If it is less than 40 degree, that angle, they are going to put this child in a brace. Now, this is a pre-adolescent body image. They're like, everybody's seeing me with this plastic thing here. So what we do in pediatrics is like this little girl. We give it some color and some pizzazz, as my mother used to say. Give it a little bit of something to make it look more, appealing instead of just the white plastic thing. Now, it is on for 23 hours a day. We want that curve to relax. We also, at the same time, will put them under physical therapy with exercising to strengthen the muscles so that we can straighten it out. Now, if it's over 40 degrees, I want you to look at the lung on the right side. You see how it's being compressed? If that curve goes more, it's really occluding that lung for the ability to expand. So that child needs surgery to get it fixed. And what they do is either the Harrington or a Lukey rods. And what it is they take and attach to the spinal cord these little attachments with a rod, and they try to make it as straight as they can. And they can't correct it completely, but they can do a pretty good job with it. Osteomyelitis, infection of the bone. Infection of the bone, you're going to see things like pain, bruising, and fever. If you see the redness and the swelling, that really will help you, make that diagnosis. Now, they'll do an x-ray. And again, with any infection, they see like this little fuzzy area on it. So usually when they come in, it's painful, they're in fever, they don't feel well. So they do the x-ray, they find it. This child is going to be on 3-4 weeks or more of antibiotics, depending how long they let it go for. This child is going to need some sort of central line. Usually they'll put in a PICC line, and this kid will be home on bed rest to let that whatever rest. Usually you'll see them on feet and toes. I've seen them there quite a bit. Now, it is a staph infection. So these antibiotics that they use are these aminoglycosides, so peak and trough levels, and we're so concerned about kidney function. So monitoring urinary output is very, very important. And then because it's an infection, nutrition, we need some good protein and good carbohydrates for this child so that they can heal well. Now, we've mentioned cancer before, but I'm going to mention 2 here or 3 that are something to do with the bone. Now, Ewingsarcoma could be any of these bones, but if you look at this picture here, that's a scapula, and it's a big tumor that's there. Usually it is in the younger children. And what they do for these kids is radiation chemo, and they try to take it out. And if we've caught it quick enough, hopefully there's no metastasis and they'll do well. Rhabdomyosarcoma comes from some sort of muscle. You can see it in the gum lines, you can see it in the nares, you can see it in the ears and the eyes, and it gets big and it's swollen. Again, these a lot of the time do metastasize. So as soon as we start to see it, they need to radiation, chemo, and maybe surgery if they can. But these kids will be on a long-term chemotherapy to make sure that it is gone. JIA or JRA, juvenile rheumatoid arthritis, again, is an immuno problem. It's the body is saying, joints, I'm coming after you, and it attacks the joints and it creates a lot of pain. Now, children, it's usually those ages 1 to 3 years old. And these children will start with, in the morning, stiffness, pain, swelling. If it goes on longer, of course, it's deformities, but usually at that age, that's what you see. So morning stiffness, difficulty walking, limp, and also uveitis, which is basically a red eye, red eye for no reason. So the one problem about JIA, it's so difficult to diagnose. Now, I have rheumatoid arthritis. It took me almost 10 years to get diagnosed. Everybody told me it was this, that. I'm like, you're wrong. Nobody believed me. And finally, they did different tests on me and said, no, you're right. I'm like, okay, now you believe in me, fine. But it's very difficult to diagnose. So what is our management of it? No, there's no cure. You have to live with it. The goal is to keep the pain to a minimum, prevent deformities, and keep whatever that joint is working. Don't let it stiffen up. NSAIDs, your ibuprofen is your drug of choice for pain for this, and corticosteroids used for those flares that, you're really suffering in pain. Methotrexate is given weekly, and then your biologics. It could be Humira, it could be Enbrel, it could be an infusion, Remicade. There's all different choices of this, but it all depends on the compliance of the family and the child doing what they need to do. The biggest thing that helps JIA is to keep the kid moving, get them in an exercise plan, physical therapy, occupational therapy, keep the kid healthy, and then just let the kid know that moving is the best thing for them. And when they hurt, just to move anyway, it will help. The other disease that attacks the body is lupus erythematosus. Now we have attacking joints. Well, lupus attacks organs. It is usually girls ages 10 to 19. As you see here, triggers are that hormonal imbalance. And it's usually when you see the onset of puberty where you see these children, these girls that are going to be diagnosed. It could be due to exposure to drugs, as in you took something and your body didn't like it. Or it could be an infection. Stress is always a trigger for JIA or even lupus. And with lupus, it's an overexposure to sunlight. So children, especially here in South Florida where I live, need to get sunscreen, and they need to limit their time in the sun to help prevent, an attack of lupus. So what do you see? I mean, I've showed you two pictures of those nice, you see them, butterfly rashes. They usually start, you'll see the rash. It's when you're doing these diagnoses. Then you'll see nausea, vomiting, diarrhea, and pain for no reasons. And then you start seeing those joint weakness and difficulties. But it gets to the point where you start hitting the neuro of that forgetful seizures, paralysis, is when they start putting the pieces together that it's lupus. The pleurisy is attacking the heart, and the proteinuria, of course, that's when it's attacking the kidneys. And those are the symptoms you would see. So our goal is just supportive. There's no cure. We just need to do what they need. Sometimes these children are on a daily dose of steroids and folic acid. All of these treatments are all different, and they're always changing. This is good, and they change them. And all children react differently, and all children are different. And that's why I love working with them, because no two children will be on the same treatment for sure. So these children need to understand what goes on and how to prevent any exasperations of going on, and again, being compliant with the therapy. So Kristen is 10, sustained a fracture in the epiphyseal plate in her right fibula when she fell out of a tree. When discussing this injury with her parents, the nurse should consider what? Well, what is in an epiphyseal plate? What is that? What does that do?
Growth plate.
It's the growth plate. Yes. So what are we worried about?
B.
Absolutely. Because we don't want a short arm, a short leg, and we don't want a crooked leg. So we want to make sure it's fixed properly. Good. Now we're going to go into some neuromuscular type of dysfunctions in children. You think neuro and you think muscles, the first thing you should think of, cerebral palsy. And basically, it is the inability to control your movements in the way that you want. Your posture is different, and this happens during fetal development or, as a child is born. I've seen hypoxic anoxic episodes that causes cerebral palsy in children. A lot of these children, because it's a neuro problem, they do have epilepsy and are treated for that too. Now, it can be caused by some sort of abnormalities in the brain. Maybe there's an occlusion. I've talked a lot about children, infants, about their brains being so fragile and that, they can get these brain bleeds easily. So it could be a little bleeding in the brain, occluded some area of oxygen, could cause cerebral palsy. Or it could be this hypoxic anoxic episode. Children born, sometimes they don't breathe right away and need to be intubated, or there's a delay in getting a child out of the birth canal and they had an hypoxic moment. Both of those things can cause, and sometimes not, but can cause, cerebral palsy. And remember, cerebral palsy is in all different levels. There's mild to severe. So how do you diagnose it? Well, if you know that there was an episode at birth, or if you're starting to see immediately some sort of this hypertonicity, you would suggest that it could be cerebral palsy. But most of the time, if it's more mild, it's going to be those assessments that we do, those growth and development assessments. Are they lifting their head up? Are they turning over? Are they doing, grasping, voluntary, involuntary? All of those things, if they're not doing it, could point towards cerebral palsy. So we will be doing some sort of neuroimaging, and of course, looking at, is it metabolic? Is it something in genetics? In case the parents would like another child, those things are important. Delayed gross motor development and fine motor development, they're not going to really have it that well. There's going to be alterations in their muscle tone. They're not going to be sitting correctly. Their reflexes are going to be abnormal, and these children, some walk, some don't walk. I mean, my little Jonathan, severe spastic cerebral palsy. And this child would see me across the room and he would start spasming. It's like tightening your wrist. And he just wanted me to come and say hello to him. And that's the spastic, probably what we think of cerebral palsy when we think of it, that more the spastic one. But our goal, what is our goal? Now, Jonathan had a wheelchair and he was able to be up and to be a part of the group, which was great. He had a pad where he could talk to us, through this electronic pad. And this is a 7-year-old. Now, years ago, cerebral palsy, we didn't teach them like we do today. Today, we are we are helping these children to be the best they can be so that they have the ability to be able to move around and to communicate, which is the best. The education that we do in cerebral palsy, we start out with little steps. And if they meet them, we're going to keep increasing them. And we are always shocked with how much that these children can do when given the time, and somebody takes the time to teach these children. And we have found that being around other kids, quote, normal kids, does help these children a lot. Because of the spasticity, ankle and foot braces, we want to keep them in a position that's functional. Maybe this kid will be able to get up and walk, but if they have foot drop because we didn't do anything, it's not going to happen. Sometimes they do surgery for these deformities. And then, pharmacological agents. I mean, little Jonathan was very spastic. They put him on carbidopa, levodopa. that they use for Parkinson's, which helped relax those spasms. And then we have botulism. We're going to use that on them too. These children do have poor hygiene in their mouths, so we really need to do it well. And again, of course, physical occupational therapy, keep their body moving. You know, the prognosis of them, these children actually do very well. And, you know, it's the other things that, you know, will depend on their survival. Usually, if a cerebral palsy dies, it's usually more of a pneumonia, sepsis that does it. It's not the cerebral palsy. So how do we take care of these children? Well, it's not just when you have them in the hospital or like what I was at, you know, Patches with, it's a daycare for these special needs children. They got a home too. They need to make sure they have the proper equipment that they need and get all the resources they can to help them at home, to be taught how to give medications to keep them safe, you know, and then making sure that they have all the support they need, you know, to take care of these children, because, you know, they do require total care at home. Now we're going to talk about something called a neurotube deficit. And your neurotube is your spinal column. There are times when you have a small head, it's anencephaly, and then you've heard of spina bifida. Spina bifida, myelomeningocele, basically the same thing. It's the spinal cord and meninges. The skin didn't close and it's born on the outside. So what you're looking at there is meninges and spinal cord. So you have stretching of all those nerves to get it up there. So that stretching has created deficits in the lower extremities. And not only the extremities, your bowel and your urine, the nerves, those have been stretched. So you may not be able to feel, they may not be able to feel if they need to urinate or move their bowels. Now, neurotube deficits happen during development, and it could be due to some genetic thing, or it could be due to mom obese, diabetes, or low B12s can also cause it. So what do we do for these children? What is our priorities? Well, because of this outpatching and the probability of multiple surgeries or procedures, immediately at birth, their latex allergy. They don't have to show that they're allergic for us to say they're allergic. Immediate latex allergy, because most of these children cannot urinate by themselves. They will be straight gaffed every 4 hours for the rest of their lives because they can't get it out. There's no nerve, there's no feeling. Also, we need to monitor their bowels, you know, and give them either laxatives or enemas or whatever we have to do to keep the bowels moving. Now, just because this kid can't move or has decreased sensation in lower extremities, their brains are perfect. Now, another story. Manuel Louis was a newborn, and mom was standing next to his warmer in the NICU, and she was crying. And it wasn't my kid, but I was in the room where she was, and I just couldn't let a mom cry by herself. So I said, Mom, what's the matter? She says, they don't know if my baby's gonna make it. I said, look at your baby, he's beautiful. He's perfect, but we need to fix this first. And once we fix it, you look like a mom who will really take care of his son. There's gonna be things you're gonna have to do. He may not have full sensation of lower extremities, but I know you'll be a wonderful mother. Okay, we got through it, baby went home. 14 years later, this woman found me down in the emergency room, and I saw her pointing through me through a door. And we show you how a couple little things, a couple minutes of time did for this woman. Well, she pulled me out, and I said, can I help you, ma'am? She goes, this is Manuel Louis. Do you remember him? And he was in a wheelchair, and he was a good looking boy, you know, with this big smile. And I went, oh my goodness. She goes, I want to thank you because your words of kindness really has helped me. And he is such a great kid. He just passed 8th grade. He just went to the 8th grade prom, and she pulled out a keychain which had a picture of me holding Manuel Louis as a newborn. You know, you don't realize as a nurse what you can do, and it doesn't take anything but a little time and a little bit of caring. That kid is in mainstream school and he's doing really well. How do we prevent most of these neural tube deficits? It is that folic acid, 0.4 milligrams a day. Of course, we should start before we get pregnant because we always know when we're getting pregnant. I didn't. Okay, let's go into some dystrophies. We have Wernicke-Hoffmann disease. This is very severe. It is floppy infant. This is, their muscles don't work, and it gets worse, and they usually die within 2 years old. Worst severe, Wernicke-Hoffmann. So, same thing. Duchenne muscular dystrophy. This is probably the most tested about diagnoses. You'll see this on HESI, you'll see this on your NCLEX. It's like that tetralogy of Fallot. They love picking on this disease. And what it is, it's muscular dystrophy. So it is a wasting of muscles. This is usually, it comes from mom, it's X-linked. So mom gives it to the child. It is mostly boys, ages 3 to 7. And what we see and get this kid diagnosed is all of a sudden they start walking and falling, and they start shuffling their feet when they're walking. Their muscles aren't working that well. And then it continues on. These kids need aggressive physical therapy, occupational therapy. And then usually around the teenage years, because muscle wasting, well, the heart's a muscle and the lungs are muscles, they fail and they usually die because of their lungs or their heart. So what do you see? Like I said, waddling gait, frequent falls, and Gower sign. And Gower sign is like me. You get on the floor, you get up, and I walk up my legs to get myself up off the floor. That is a Gower sign. And these young kids are doing it. These children, because they're not as mobile as they should be, they tend to be a little bit overweight, and they are a little bit cognitively impaired. So there's really not a lot of treatment to do. These children, to diagnose them, they usually do an EMG, electromyography, where they test muscles and responses to stimuli. And because they have the symptoms of shuffling gait, falling down, Gower sign. So they're trying to diagnose it so they know what treatment to do. But basically treatment is just to keep their muscles moving. Range of motion, physical therapy, bracing, and then of course, if the mother wants another child, genetic counseling. Guillain-Barré, infectious polyneuritis. It's viral, so it's not an infection, but what it is the nerves start to stop basically working. And it starts from the feet and it works upwards. So ages 4 to 10. What you'll see is, again, the shuffling, falling, and then you start to see incontinence, because now it's going ascending, feet upwards, incontinence, then you'll see constipation. And our biggest concern is it's going to go up and hit the phrenic nerve. Now you're not breathing. So nursing priority, watch respiratory on this child. And the treatment is IVIG and maybe steroids. And we are going to have some respiratory support. These children usually end up intubated. If it lasts long enough, they're going to be having a trach. And then what happens, all of a sudden, they start taking breaths. And then the paralysis goes back down to the feet. And it will require physical therapy and therapies afterwards to get those strength again. tetanus, lockjaw. Lockjaw tetanus is this muscles get rigid, and it's right around your neck. So go like and see how that feels like, and you can feel it, and the whole neck gets stiff and it's painful and it swells, and then it starts, you can't swallow, and then it affects your airway. And then it goes down to your abdomen, it goes to your legs, and then it goes, and because of it's all tight around the respiratory, you are going to go into respiratory distress. So these children will need to have very powerful muscle relaxants. Usually we'll intubate them, protect the airway, and we'll paralyze them and sedate them. If you get to day 4, these children usually will recover, but most of these children do not make it. It is a really horrible disease. That's why we all get tetanus shots. How often? Every 10 years. And if there's an insult where you've got a cut, they're going to give you a booster. So what is the management of it? We are going to do the tetanus toxoid or tetanus antitoxin, and we are going to clean the wounds. Soap and water, we don't need to do more than that. If it's more oozy and more of a big thing, clean it more antibiotic ointments, etc. And we are going to monitor respiratory. We're going, of course, take care of the lungs with that muscle relaxant, and give them time, and hopefully they make it through. Botulism due to honey, Caro syrup. There are some cultures that believe if an infant does not stool or having a problem with constipation, give them a little honey, give them a little bit of Caro syrup, but it could be dangerous. And the reason is because, is it sterilized? How old is it? How long has it been sitting there? When it was prepared, was it sterilized before you got it? So never ever give an infant honey or Caro syrup. What do you see if you have botulism? All of a sudden you get the weakness, vomiting, and then it goes into respiratory paralysis. All of these hit your lungs in one way or another. So we treat it with IV botulism immune globulin, and we're taking care of the lungs by ventilation, and of course, always, following up with the nutrition. Now, I worked in the emergency room, which is a level 4 trauma center, and I was one of the primary nurses for trauma. And I many times got a child in with spinal cord injuries, like that 16-year-old I talked to you about. It could be motor vehicles, sports. Even when the child is born, aren't we pulling the neck, which is the spinal cord there? Sometimes birth can cause these things, or that hyperflexion, hyperextension, hit by a car, your head goes back and forth. Those things can cause spinal cord injuries. So nursing priority, immobilization of wherever. Now, on the scene, EMS will take and put the hard collar on, we'll tape even the forehead to the board, the arms, everything's taped so this kid can't move. And then the kid comes to us. Your job, I don't care about vital signs yet, keep that whatever immobile. Now, that 16-year-old that I had with this angulated C5, C6 fracture, already with paralysis on the right side and numbness on the left leg, these are on the feet, the left foot, I was scared, okay? Not only did I have to do x-rays, I had to bring him to the MRI room. I had to get him off the board, onto the MRI table, and I had to protect that neck, okay? My job. And let me tell you, I took it very seriously. We did well. We got the kid done. We saw the thing. We put him in the tongs. We put him in the ICU. The next day he went to surgery. We fixed it. I saw him 2 weeks later. He was moving both his legs, slight numbness. He was going to therapy, and the end result, the kid is perfectly fine because somebody took care of that neck. So priority. I mean, all the other stuff wouldn't have mattered if I would have neglected that neck. So nursing priority, immobilization. So a progressive infantile spinal muscular atrophy and the most common paralytic form of floppy infant syndrome. And I'll give you guys a break. It's Werdy Goffman's, okay? It's the floppy infant. So that's today's lecture. A lot of stuff, a lot of stories. Who wants to win a Cahoots? Anybody? Maybe. Ariel, you want to win. Jessica wants to win. So does Vanessa and Jennifer. Wendy, yeah. All right, let's do it. There's like 39 questions, I believe. So we'd be out a little bit early. All right, let's get going so you guys can go on with your evening. A multi-select. What is the priority for a nurse to assess following a cast application? Everything. Pulses, movement, pain, sensation. Very good. And we need to teach the family this and the child for sure. What should the nurse monitor after a soft tissue injury? You got a big bruise, a big ecchymotic area. What are we concerned about? And we're going to check neurovascular signs. Remember that swelling could occlude blood vessels and blood might not get down distally. So we want to make sure that we have pulses, that we have, capillary refill. The color is good. We need that. A fracture that penetrates the skin is called. I mean, there's all sorts of fractures, the ones that crack, the one that's buckles, there's green sticks which bends. But there's one that penetrates the skin. And that's our big concern for infection. And it's called a compound. Simple is just a little crack. That's all it is. Compound is when it goes through the skin. And now this child needs antibiotics. What is priority nursing care for a child who fell off the second floor balcony? And I've seen this. As a nurse, you're going to see all sorts of things that you just shake your head. What was the kid doing on the balcony and falling off? Again, strict immobilization of that spine. Neurochecks aren't going to matter if that spine is not put together. Then we'll do neurochecks. Of course, we're going to worry about brain bleed, etc., checking pupils. We could have a neurological emergency. I get that, but keep that spine. Principles of managing soft tissue injury include RICE, RICE. Absolutely. Good job. Epiphyseal plate fractures in children may what? So when you talk about epiphyseal plate, we're talking about growth areas, and we're always concerned about the growth of the bone, and we're worried about making sure that it's straight so that there's no deformities. Those fractures, usually I've seen them in the elbow, go to surgery. Open reduction, plates, screws, make sure it's straight. What findings for a patient in skeletal traction indicates peripheral neurovascular impairment? So when you talk neurovascular impairment, you think of pulses, okay? So no pulses or prolonged capillary refill, those both would show it. How should the nurse care for the skeletal traction for a child with a fractured femur? Now remember, we've got this buttocks traction. What is our priority care there? So it's this weight, the string is pulling and it's holding that leg straight, keeping that femur so there's no pain, there's no muscle spasms. Make sure those weights hang freely, you know, and there's nothing in its way. Also, make sure that you document how much weight is on there every shift. When caring for a 9-year-old in buttocks traction, what action by the nurse is correct? I mean, buttocks traction, it's a fractured femur. So we're always, when you're talking about traction and a fracture, distally, make sure capillary refill, and check it quite frequently to make sure that swelling is not occluding any blood flow. A multi-select. Which assessment indicates an infant has developmental dysplasia of the hip? So Morrow has to do with a startle. Babinski has to do with the feet splaying, nothing to do with this hip dysplasia. It's those asymmetric leg folds. So you have one leg higher, so you're going to have the folds different. And also your positive ortolani. You're going to hear these clicks as you be moving them around. What statement by parents indicate more teaching regarding their infant with club feet? How did I tell you we treat club feet in infants? Infants, they heal very quickly. We said that casts could be 2 to 3 weeks. So we know that we're going to do the Ponseti method and we're going to do serial casting. So we will be doing the casting as soon as we can. They are going to have follow-up care until they're grown to make sure that their feet are progressing in the right way. And they're not going to have any crooked ankles or feet. Also, it's every week. It's not every month. So it's every week. It's a new cast put on that child. Every month is too long. Albert, you're on fire. Multi-select. Osteogenesis Imperfecta. That's my little kid who used to bypass me and go beep, beep. I miss being in the hospital and seeing these kids. I do. So osteogenesis imperfecta is brittle bone disease. It is an autosomal dominant. We are going to do no aggressive physical therapy because we're going to break some bones. Now, the problem with osteogenesis imperfecta, sometimes it's not diagnosed, and sometimes these parents are accused of child abuse. So it is one of those diseases that I've seen that happen to. I've heard news stories of them. When can osteogenesis imperfecta be the most life-threatening? I asked the question, do we know before they're born that they have this? I mean, why would you suspect it? I don't know. But coming through that birth canal, squeezed, they could have fractured clavicles, fractured ribs, fractured, spine. That is where it's the most concerning, trying to get these children born. Now Ari's on fire. What is the pathologic cause of leg calf Perth disease? And if you look at the top of that femoral head, you see that fuzz? That is what that necrosis type of inflammation that's going on. That's what it looks like. Remember, it's a lack of blood supply there. It's ischemic aseptic necrosis of femoral head. Treatment, bed rest, NSAIDs, and maybe some traction for relief of pain. And Wendy's on fire. Kyphosis. Which one is that? Kyphosis, lordosis, and scoliosis. And that's the humpback. That's that lumbar, the thoracic spine that humps. It's, postural. You look like you're, humped over. Lordosis is described as what? And I think that little girl picture is perfect. And that's the inward curve of the lumbar spine. We see that one with the Duchenne muscular dystrophy. Scoliosis is remember, scoliosis is that S-shaped curvature. It is something that less than 40% we could treat with a brace and physical therapy. And more than that, it will need surgery because it's going to start impede upon that lung. Adolescents with scoliosis that have 25% curvature of the spine would need to what? So 25% doesn't need surgery. This is the brace 23 hours a day. And of course, with physical therapy, strengthening those muscles, exercising. What is osteomyelitis? Osteomyelitis is an infection of the bone and requires some sort of central line, like a PICC line, and it requires a long-term IV antibiotics. And our biggest concern is because it's staph, they're using the aminoglycosides. We're concerned about the side effects, kidney problems, and to monitor those lab values as close as we can and let those parents know that's very important. Juvenile rheumatoid arthritis is and what? It's an inflammation of the synovial joints. The bone body says, joints, let me attack you. Let me create inflammation and pain. It's not nice. Goals for juvenile idiopathic arthritis include what? So with GIA, we just want the joint pain to be as decreased as possible. And of course, let this kid be a kid. Their stiffness in the morning, but hopefully the rest of the day that they can enjoy. Systemic lupus erythematosus is what? And it's an autoimmune disease where the body attacks organs. And Albert's back on fire. A multi-select. What can a child with lupus erythematosus do to prevent exacerbations? Well, we know decreasing stress always is a thing, or even infections can cause, exacerbations, flares. So sunscreen, and of course, decreased exposure to sunlight. But this is the one that you're going to give that prophylactic before procedures like dental extractions, antibiotics, and steroids, and that helps prevent them. And now Jessica's on fire. What organs can lupus affect? Everything, heart, lungs, brain, skin, kidney, liver, doesn't matter. Any organ, it will affect it. What is cerebral palsy? So cerebral palsy affects body movements and muscle coordination. Very good. Myelomeningocele. What's that one? Remember, with this one, we're concerned about the stretching of the nerves. We're going to have decreased sensation and movement, and we worry about urine and bowel. So it is a hernia or an outpatching of the spinal cord and meninges. As a nurse, our goal at birth would be to cover it with a dry, sterile dressing. And then after surgery, the child will be getting therapies for the lower extremities. Now, Jessica's on fire again. Infants with myelomeningocele demonstrate what? So again, because of the stretching of the nerves, motor, sense, and all different levels, some there'll be some sort of deficit, but some are complete and some are just, they still can move a little bit. Due to the decreased motor and sensations of the lower extremity, what must a nurse monitor closely on a myelomeningocele? And that's urinary retention. Think about the nerves in the lower spine and they're stretched and they're not functioning. What does it, service? Well, it services down, and down is the bladder and the bowel, and of course, movement of the legs. Our biggest concern is urinary retention. So we will be monitoring that closely, maybe having to do straight calves every 4 hours. A key feature of Duchenne muscular dystrophy is what? Well, just look what the word says. Muscular dystrophy. It's all about progressive muscle wasting. And again, they usually as teenagers, because of the heart's the muscle, lungs, they will die of failure of either the heart or lungs. What is one of the procedures that a child with possible Duchenne's may need to diagnose the condition? Well, when you're thinking Duchenne's, we just talked about it, it's muscle wasting. Which one of these evaluates muscles and their functioning? And it's the EMG. And remember that I've had an EMG, several years ago, but because I had some nerve problems or neck something going on with spasming of nerves down my arms, and they gave me an EMG. And what they do is they shoot impulses into nerves and your arms spasm and it hurts. So make sure that we medicate these children, before they go down, because they're gonna hurt if you don't. And now Ari's back on fire. How is Duchenne muscular dystrophy inherited? Where does it come from? And it's mom, X-linked recessive, it comes from mom. That's why if they want to have another child, they need to have some genetic testing. And now Albert's back on fire. In caring for a patient with Guillain-Barré, the priority concern is what? Remember, Guillain-Barré is viral. It starts ascending, comes from the feet, starts to work up. What is your priority? Remember, it affects the phrenic nerve. So respiratory can stop working. So maintain your airway and monitor it closely. Nursing priority, airway. For a patient suffering with Guillain-Barré, they would complain of weakness. That was what? And it's called ascending, which means feet up is ascending. Head down is descending. A multi-select. Treatment for Guillain-Barré include remember I said this is a virus. Antibiotics are going to do nothing. You don't need heparin. It's IVIG, IV immunoglobulins, and of course, respiratory support, keeping the lungs working. And Ari went up top. What type of cerebral palsy causes hypertonicity, poor fine motor skills? This is my little Jonathan. Remember, he's on levodopa, carbidopa that they use for Parkinsonism, and it is spastic. This is probably the most common. You think of of cerebral palsy, you think of the spasticity and you think of spastic cerebral palsy. What priority action should a nurse take to a patient with a suspected spinal cord injury? Priority. Thank you. Immobilize that spine, take care of it, prevent that child from not moving again. You should get a tetanus shot every how many years? And it's every 10 years. And you also are going to give a booster if there's any sort of cut or something that happens in between. And today they're giving tetanus with diphtheria combined. That's the new train of thought. About 10 years ago, they changed that. Which is a symptom of tetanus? It's lockjaw, and it gets so painful and so tight. Now it's all about respiratory and maintaining the airway. And hopefully the tetanus toxoid immunoglobulins will turn it around. Remember, on day 4, if they're still going on, maybe they'll make it. Before that, then they would have, they'll die before then. Last question. Most common cause of spinal cord injuries are what? Accidents, motor vehicle, driving, sports, absolutely the most common at all. Let's see how we did. Number 3. Look at that, Donna, good job. Number 2, Ari. And number 1, Jen. Good job, guys. Number 4, Claudia and Jessica. Good game today. You guys kept changing positions. What I'd like you to do is sign your attestations, get them done so that they're done. Can I help anybody with anything, any questions I can help you with? I will be doing the first review tomorrow night at 5:30. Again, it will be recorded and posted for you. It will be in my YouTube channel. Do you realize my second review had 685 views? And most of them were 30 minutes or more. So they're really paying attention. So that really makes me happy that you're using it and you're listening to it. So I'll continue to post them. You keep continuing to listen, okay? So send me your projects, anything that you want to improve your grade if you want, and I'll do that up till Sunday night, okay? Anyway, thank you guys. Have a good night. Thank you.
Good night.
Good night, guys.